Hello, everyone. Can you guys hear me? Please write in the comment if you can hear me. Great. Awesome. All right. Let's get started then. Hope you guys are doing great. Okay, now let's talk about two important high yield topics. The first is diabetic ketoacidosis, and the second is hyperosmolar hyperglycemic state. Okay, so in diabetic ketoacidosis, and these are all hyperglycemic emergencies. So, what do we mean by that? Both will have hyperglycemia. Both will have hyperglycemia, but in your HHS, which is hyperosmolar hyperglycemic state, as the name suggested there, hyperglycemic state, you're going to have a glycemia greater than 600. But in here, the other one, diabetic ketoacidosis, you're going to have hyperglycemia of, let's put it greater than 300, okay? But although it is hyperglycemia, but look at the levels, way too high here, right? So with that, let's look at the pathogenesis. Okay, so pathogenesis, here we got for the pathogenesis, for the diabetic ketoacidosis, you have insulin non-compliance or increase in requirement due to increase in stress. For example, infection. So whenever you have increase in stress, you're increasing the requirement for insulin. You need more insulin. So when would you have increase in stress? So they only mention infection here. So let's just write more. For example, you're going to have increased stress when you have infection. One thing. Second thing could be when you're in pain. You're gonna have that's essentially causing increase in stress. Okay. Other than that, you have sleep deprivation, severe mental, emotional distress. All of that would increase the stress. And that with increased stress, you're going to cause increase in lipolysis and oxidation of free fatty acids. Okay. And that's going to cause increase in ketone bodies. Which ketone bodies are we looking at? High yield, and you will see that in biochem. The ketone bodies are beta hydroxybutyrate more than acetoacetate. Okay. So with this, what is the pathogenesis here? With DKA, diabetic ketoacidosis, you have insulin, which is deficient, but you have ketones, which are present. Okay. Again, let's go back to pathogenesis. What do we talk about? Simple thing. Either you don't have insulin, insulin non-compliance, okay, you're not taking your insulin, or there's an increase in requirement, but you don't have that much. And why would you have increase in requirement? Because there is an increase in stress. So all of that is essentially saying when you have absent or deficient insulin, it's going to go into lipolysis. Free fatty acid will go into the blood, causes increase in ketone bodies, which are going to be your beta oxybutyrate greater than acetoacetate. With that, let's compare this with the HHS. You will have profound hyperglycemia. Again, very high yield. When you see something profound hyperglycemia, you are going to think about HHS. Okay. With this hyperglycemia, let's say more than 600. This is going to cause excessive osmotic diuresis, right? That's because all that glucose, again, if you recall, what is the level of glucose where your normal reabsorption of glucose the all the transport mechanisms in the kidney would just go in saturation. If you go in your kidneys, it's about 295. So when you hit this level at 295, guess what's going to happen? Every particle of the glucose is going to go straight in urine, okay? Because you lose the capacity to reabsorb that glucose once you're above 295. So here we're looking at 600, okay? Way too much. And that's going to cause what? All that glucose, wherever the glucose goes, where it's going to draw that water in with it, right? So in the urine, you have a lot of glucose, it's going to draw all that water. It's going to cause osmotic diuresis, which is going to lead to dehydration. And when you dehydrate the serum, now you don't have free water in there, your osmolality of the serum is going to go high, right? And that is going to lead to your, as the name suggests, hyperosmolar. There's increase in osmolality of serum, hyperglycemic. Again, you got increased glucose level in the serum. State is the state, HHS, okay? Classically seen in wear in older patients with type 2 and limited ability to drink. So if this is with type 2, where would you see DKA? Mostly you will see it with your type 1 diabetes. So type 1 diabetes in young patient, okay? Because type 1, you will see that in young. So that's mostly, okay? Majorly, you will see it over there. So this is all the pathogenesis. With that, let's look at sign and symptoms. With sign and symptoms, DKA is deadly. That's the mnemonic. Delirium, psychosis, cusmal respiration, which is rapid, deep breathing. Cusmal respiration. We will talk about every single detail of this, like why this is happening and all. But here, just reading here, abdominal pain, nausea, vomiting, dehydration, fruity breath odor due to exhaled acetone, okay, which is a ketone body, okay. On the other hand, sign symptoms for HHS is going to be thirst, polyuria. Again, symptoms of diabetes, right? Thirst, polyuria, lethargy, focal neurological deficit, but seizures. Two extra things: focal neurological deficit and seizures. What are going to be? What will you see in the labs? Well, the labs, again, hyperglycemia, about greater than 300. That's important. On top of that, you will have increase in hydrogen ions, decrease in bicarb. We will talk about how we got to this point that we have increase in hydrogen, decrease in bicarb, which causes increase in anion gap metabolic acidosis, increase urine and blood ketone levels, leukocytosis, normal and increased serum potassium. Okay, normal or increased, right? But depleted intracellular potassium due to transcellular shift from decreased insulin, high yield, and acidosis. Let's actually talk about this first because this is very high yield. So let's go with this. Okay. So when you have insulin deficiency, right? That's the whole key mark in your DKA, right? In DKA, all you have is insulin. Never forget this. DKA, no insulin. Okay, there is no insulin. There are ketones which are present. Insulin is absent. Which disease is it? Type 1 diabetes, which is essentially absolute insulin deficiency, right? So let's talk about this in detail now. When you have insulin deficiency, what's going to happen is now the body needs glucose, right? So insulin deficiency, the other counter-regulatory hormones will come up. Which is the counter-regulatory hormone for insulin which works right against insulin? That's your glucagon. So when your insulin is deficient, you're essentially stimulating glucagon, because when your insulin is there, it's going to inhibit the glucagon secretion. So when it is not there, the glucagon just gets released. So when the glucagon comes into bloodstream, it causes a couple things. It causes these two things, lipolysis and ketogenesis. So let's just put it here. Increase in lipolysis, one thing. And the second thing is going to be your in ketogenesis. So lipolysis, as you know, is going to release those free fatty acids, which are mentioned here. Let me erase this so maybe it can be an easier way to understand. Okay. Lipolysis, so increases lipolysis, which causes increased free fatty acids, right? right here. Those free fatty acids are going to go into ketogenesis, formation of ketone bodies, right? And that ketogenesis forms the ketone bodies, which are going to be your beta hydroxybutyrate acetoacetate, right? So that's one thing with the glucagon. Other thing with insulin deficiency is going to be that it's going to decrease potassium intracellularly and in total body, but there's going to be increased potassium in the extracellular fluid. And the question is, why would that happen? Well, let's dive deep into that question. Why would you have decrease in potassium? Okay, so for that, we have to understand the ketone bodies. These ketone bodies, they are going to cause a couple things. One thing they are going to cause is ketonemia. So let me do this way. Make things a little better so you can, ketones, right? Ketones. We got the ketone bodies here. So these ketone bodies are having a couple things. So first of all, they're utilized by the body, by the tissues, right? So tissues are getting ketone bodies, they're good to go. Now, these ketone bodies also going to go in urine, so lead to ketonuria, okay? Ketonuria, that's one important thing. Then also, they will stay within the serum, so ketonemia. Now, this ketonemia, it's going to cause acidosis. And that acidosis is going to stimulate a couple things. So first thing is going to go, this ketoacidosis will be sensed by the medulla, and that medulla will be like, hey, we got a lot of acid, we want to get rid of it, right? So it will stimulate the respiratory center, and that's going to cause your cusmal breathing, which is your hyperventilation. So let me write it here. It's going to stimulate hyperventilation. I'm just going to write RR, which is your respiratory rate. Increase in RR, which is the respiratory rate, hyperventilation, in other words, which is cusmal breathing. Again, here we talked about in the book cusmal breathing, respiration rapid, which is increasing respiratory rate, and deep breathing, which is cusmal breathing. Why did it happen? Because acidosis would stimulate the medullary receptors, which would then in turn cause the respiratory centers to go high, causing hyperventilation. And the question is, why are we hyperventilating? Well, we are hyperventilating so that we can get rid of carbon dioxide, which is an acid. We have acidosis. We want to get rid of acid. Simple as that, right? How do we get rid of acid? Well, we want to get rid of carbon dioxide by hyperventilating. You hyperventilate, you blow out more carbon dioxide outside. You are going to have low CO2 within the body, right? So that's going to cause normalization, right? Again, this is very important. It's going to come up in acid-based disturbances. What do we have here? Again, it's the metabolic acidosis we have. That metabolic acidosis is corrected by causing compensatory respiratory alkalosis, right? So that will make more sense when we do the other things, which is in the respiratory, which is in the renal. But here, important thing, you got acid, you want to get rid of acid, push that CO2 out. And with how are you going to push it out? By doing a lot of rapid respirations. And that's called cusmal breathing, okay? That's one thing. So now with the ketonemia, the whole problem was ketonemia here, right? Now the ketonemia doesn't stop here. It doesn't just stop here, but also with this ketonemia, it's going to stimulate as this acidosis, right? So it's going to cause acidosis. This acidosis is also going to stimulate other things. For example, it's going to stimulate your potassium hydrogen pump. Okay. And why is that? Because you are already in acidosis. So the body will be like, hey, we don't want, and again, H is your hydrogen, they're also acid. So they were like, hey, we don't want this acid here now. We don't want these hydrogen ions in the body. We want to push them into the cell, man. Push them into, we want to see it. We don't want to see them in the bloodstream. Push them in the cell, right? So what they are going to do, there's a pump. Every cell has this potassium hydrogen pump. This acidosis will push that, will activate the pump, and the hydrogen is going to go in the cell and potassium is going to come out of the cell within the ECF, extracellular fluid. When the potassium comes out, now here's the problem. When the potassium comes out, we were already having this a lot of osmotic diuresis. So this extracellular potassium will just go out in urine with the osmotic diuresis. So we are going to lose all that extracellular potassium. Okay, and we have increased level of intracellular hydrogen ions. Okay, so with that, all pathophysiology, let's read the book now. Okay, we said cuspal breathing makes sense. Abdominal pain, nausea, vomiting. Okay, dehydration. Dehydration is also going to be there because you are causing what? Again, osmotic diuresis leading to dehydration. You have ketone bodies, so fruity breath odor is going to be there. For the labs, hyperglycemia for sure. Now you look at this increase in hydrogen levels, right? Decrease in bicarb to increase the anion gap metabolic acidosis. Okay, when you have due to ketoacidosis, right? Due to ketoacidosis, you have increase. Why would you have increase in anion gap metabolic acidosis? Due to ketone bodies, ketoacidosis. Okay, and you have then you have increased urine. That all that ketone is going to go in urine and in the blood, called ketone levels high, right? Leukocyte, this is also going to cause leukocytosis, and then normal or increase serum potassium. Look at that word, serum potassium. Why? Because when you're pushing that potassium out in the ECF, extracellular fluid, it's at the time you're checking, it either could be normal or could be increased. Okay, but eventually, but you have depleted the intracellular potassium. Why? Because you're taking everything out of the intracellular, you're pushing it out here in the serum and taking it out from the cells, within the cells, due to transcellular shift from decreased insulin and acidosis. So there's a couple of things. Insulin also puts the potassium back into the cell. First of all, we don't have insulin. Second thing is the acidosis, which I explained here. Okay, and that acidosis is going to activate this pump, which will also push out this potassium, right? Then you have osmotic diuresis. Again, whatever potassium you had, you're going to lose in urine, and leading to total body potassium depletion. Total body potassium depletion, simple as that. Okay. And the last, let's talk about, since we are here, just to talk about complications here. The complications are going to be your life-threatening mucormycosis, high yield, life-threatening mucormycosis infection. Okay. Important, high yield. It is usually caused by a rhizopus infection. Okay. And then you have cerebral edema, arrhythmia, high yield arrhythmia. Okay, so how do you treat it? Well, treatment is simple for all, but here for both of them, you're treating by giving fluids, because you're essentially in dehydration state. Give fluids, give IV insulin, and potassium to replete the intracellular stores. Glucose may be required to prevent hypoglycemia from the insulin therapy. So when you give insulin, there's a propensity that you could go into hypoglycemia. So you also give glucose to not go into, or to prevent hypoglycemia. Okay, with that, let's look at this HHS. HHS is going to be, again, you have thirst, polyuria, lethargy, focal neurological deficit seizures, hyperglycemia, increase in serum osmolality because you have all that glucose in there, greater than 320, normal pH. Again, very differentiating point here. You had acidosis there. Now here you have normal pH. Okay, because there are no ketones body, so there is no acidosis. no ketones. So no ketones and no acidosis, pH is going to be normal. These are a couple differentiating features versus the other one where you have ketone bodies, where you have acidosis, and also where would you have? You would also have this decrease in pH. Here is normal pH. Normal increased serum potassium and decrease intracellular potassium. So there is decrease intracellular potassium here as well, but this is not the feature that we say, hey, this is the hallmark or something. But here we have proper depletion of potassium. Total body potassium depletion is DKA. Okay. Then you have the complication can progress to coma and death if untreated. Treatment, again, same treatment. So what are the common things? Let me erase all this and go with the summary here. Okay, so what are the things that we might see just with DKA? First of all, you got to know there is insulin deficient. The insulin deficiency, ketone present. Here you have insulin present, ketones deficient. You have acidosis, increase in hydrogen, metabolic acidosis. Here you have normal pH, no ketones, no acidosis. Okay. Hyperglycemia greater than 600, hyperglycemia greater than 300. Okay. Because you have ketone bodies present, you will have fruity breath odor, right? And that's with the ketone bodies being there is also is going to lead to delirium, which is altered mental status. And what else you might have? Dehydration is in both, so no, we can't think about that one. But yeah, that's pretty much what we have for this as comparison. Okay. Okay, one thing to add here, why would we have this shock, comma, death here? So here we have dehydration, right? So where's the word dehydration? Here, dehydration. What in both, essentially both cases, we have dehydration, but here because of a lot of hyperosmolar serum and leading to a lot of that glucose going to the urine, we have a lot of dehydration. That dehydration will essentially going to cause shock in the first of all, think about this: hypotension. Hypotension will cause shock in the patient, and that shock will cause coma and death in these patients. Okay, that's going to be all for this one. So let's move on with the next topic. And that is your hypoglycemia and diabetes. Now we're looking at hypoglycemia in DM, diabetes mellitus, right? Why would we have hypoglycemia? Well, it usually occurs in patients treated with insulin. So when you treat the patient with insulin or insulin secretagogue, which is essentially secreting insulin, example, sulfonylureas, meglitinides, in the setting of high dose treatment. So either you are giving high dose, important, high dose treatment, or the patient had skipped a meal, inadequate food intake, or the patient wanted to exercise. Okay. So again, if you think about it, you have a patient, right? The patient takes insulin. Okay. When the patient takes insulin, the insulin stays there and slowly it secretes within the body. When you go in, the patient goes into exercise, exercising muscle, again, if you go back to physiology here, exercising skeletal muscle, they are going to put on their GLUT4s on top of their cell membranes because they're exercising. They don't need insulin. So what they're going to essentially cause, they're going to put all that glucose into the skeletal muscles. So you, first of all, you are going into hypoglycemia. On top of that, You also have insulin now, which is going to put whatever remaining of glucose is there, because insulin is slowly coming down in the bloodstream, right? So that's again is going to cause more glucose to go into the cells, leading to uh, leading to more and more hypoglycemia, right? So that's a very problematic thing, right? So that is why we have to be careful in insulin dosage and how the patient, lifestyle patient, or how are they going to, and educate the patient basically. Very high yield when they're taking insulin. So again, high yield point, if a patient is taking insulin, so a couple things can go into hypoglycemia. Overdose of insulin. The patient took more dosage of insulin. They have skipped a meal, or they went into exercise, because exercising muscle, they do not need insulin. Okay. With that, let's look at more details here. We have the neurogenic cause. Neurogenic is autonomic symptoms. For example, okay. So we are talking about hypoglycemia sign symptoms here. Neurogenically, the symptoms we are going to get are your diaphoresis, tachycardia, tremor, anxiety, hunger. Allow the perception of decreased glucose, hypoglycemia awareness. So these all symptoms, they are allowing you to say, hey, we need glucose. And what are they? Diaphragm, sweating, tachycardia, tremors, anxiety, and hunger. And that is done through autonomic neurogenic pathway. Then you have this neuroglycopenic symptoms, which are altered mental status, seizures, death due to insufficient glucose in CNS. When that glucose does not hit in CNS, when it does not go to CNS, it's going to go into the CNS, will go into altered mental status, seizures, even death may occur in the absence of preceding neurogenic symptoms in patients with attenuated autonomic receptors. Example, beta blocker use, i.e. hypoglycemia unawareness. So if you block, again, that is why beta blockers use, they cause a problem here. So look at this beta blocker. Beta blocker use would inhibit your autonomic symptoms. So even if these symptoms are inhibited, so the body doesn't even know that they're going into hypoglycemic state. Okay. By the time that hypoglycemia hits the CNS is not getting glucose. The CNS doesn't wait. He's like, dude, like, where is glucose? You're not getting glucose. Okay, I'm going into altered mental status, seizures, and then causing death if there is insufficient glucose. And who's blocking these all normal symptoms? Your beta blocker. So again, what is important thing? Beta blockers mask hypoglycemic symptoms. Beta blockers mask hypoglycemic symptoms. Here they mention hypoglycemic unawareness because you are not aware of those hypoglycemic symptoms. Okay. Now treatment, simple carbohydrates, glucose tablets, fruit juice, IM glucagon, high yield, intramuscular glucagon, IV dextrose. Okay. Let's go a little further, dive in here and talk about what are the mild symptoms, mild, severe. Okay, let's just mention it here. So mild symptoms of hypoglycemia are going to be your anxiety, tremors, sweating, okay, which are fast acting. Now, to treat your mild hypoglycemia, all you need is this oral intake of carbohydrate. For example, you can give a glucose tablet. So let me just put a glucose tablet. You can give a sweetener, fruit juice, hard candy, anything, right? Fruit juice, hard candy, any carbohydrate. That's for the mild hypoglycemia. Then there's something called severe hypoglycemia. And that severe hypoglycemia is this one, in which, and the mild was here. Okay, the severe hypoglycemia would cause it develops confusion. The patient will go into confusion, loss of consciousness, eventually going into seizures and then death. Okay, and these guys, the severe one, is treated by, there are two things now. Either you see on the roadside, you have someone who's diabetic patient, and he's going into these alternative status seizures. You think it's glucose. Then on non-medical settings, in a non-medical settings, you can give them buccal or sublingual glucose. Sublingual glucose, okay, glucose. That's one thing. Or you can, if they might have glucagon kit, or you might just get glucagon kits. So there is something called glucagon kit. Okay, these kits, they are delivered either IM, intramuscular, or subcutaneous, which is mentioned here, IM glucagon. And this is only in severe cases, okay? In the severe hypoglycemia, where you're seeing these symptoms, seizures, altered mental status, loss of consciousness, all of that. But in the medical settings, example, you're in hospital, you're in ER, you are just going to give IV glucose, which is dextrose. IV glucose and dextrose, 50% dextrose and pure. So IV glucose or dextrose. Glucose is dextrose, okay? But yeah, that's what we have. Now, again, I talked about, again, very high yield, mild, severe, different treatments. Now, let's talk about something called symptomatic hypoglycemia, which you will hear in the questions. Symptomatic, or you will see the symptoms, which is going to be your simple, which is disorientation, sweating, and palpitations. And this can be relieved by giving glucose. Relieved by glucose. Symptomatic means any symptoms that can be there due to hypoglycemia. And that is all for hypoglycemia and diabetes. Importantly, you're going to think about increased dosage of insulin, or your insulin secretagogues, skipping a meal. Hey, I'm diabetic, I want to skip a meal, but taking insulin and skipping a meal, wow. So that's another story. Exercise. I want to lose some weight. Morning dose insulin, go for a walk, do a 5-mile run, exercise, see what happens. Okay, then you have treatment. What is the treatment? You have simple, we talked about it. Don't worry about this. Okay, the next thing we have is Cushing's syndrome. Cushing syndrome. Okay, Cushing etiology. Again, Cushing, increase in cortisol due to a variety of causes. Exogenous glucocorticoid. You gave someone exogenous steroids, prednisolone, anything. Exogenous glucocorticoid causes what? Decrease in ACTH, right? So exogenous cortisol, let's put it here, cortisol, is going to inhibit the production of ACTH, and that is going to cause bilateral atrophy. Again, which layers are going to be getting atrophy? Let me put it GFR. So your G was stimulated by your angiotensin 2, right? F and R were stimulated, which are two big layers again. They're stimulated by your ACTH. So when you don't have ACTH, your F and R are going to go down, but it's going to go into atrophy. Okay. Bilateral. Why bilateral? Because when you don't have ACTH that comes from top, you are going to cause bilateral adrenal atrophy. Simple as that, which is the most common cause. Second thing is you have primary adrenal adenoma. Let's say this is the adrenal gland, the kidney and adrenals. So you have adrenal adenoma in one place, in one of the adrenals, or you might have hyperplasia of that one of that adrenal, or carcinoma of that adrenal. So you are producing, let's say you're producing all that cortisol. That cortisol is again will go up top, inhibit anterior pituitary to not secrete ACTH. Okay, and that is going when you don't have ACTH, the other normal one will go into atrophy. But you have one which already has either adenoma, hyperplasia, carcinoma. These three wordings here, it is already enlarged. So you have atrophy of uninvolved adrenal gland. So one is going to be enlarged and the other one is the one which is not involved, small, because you're not getting ACTH from top. Okay. The next one is ACTH secreting pituitary adenoma. You have ACTH coming from the pituitary gland. So you have a lot, let's just erase this part. You have a lot of ACTH coming from top. When you have ACTH coming from top, guess what's going to happen? It's going to stimulate the left side and the right side equally. So both are going to go into hyperplasia or enlargement, so which is known as Cushing disease here. Again, Cushing disease versus Cushing syndrome. What is Cushing disease? Important. Cushing disease is when you have ACTH secreting pituitary adenoma. ACTH coming from top is called Cushing disease. Okay. Or you could also have, for example, paraneoplastic ACTH secretion, example in small cell cancer or bronchial carcinoids. They will be secreting the paraneoplastic ACTH, which again, both of these are going to cause increase in ACTH essentially, which is going to cause bilateral adrenal hyperplasia, simple, right? And the Cushing disease is responsible for the majority of endogenous cases of Cushing syndrome. They're saying this guy, ACTH coming from the top, is the main culprit causing Cushing syndrome. Okay. With this, just remember, again, important thing, when you're taking something from outside, exogenous taking, you're decreasing ACTH, you're causing bilateral atrophy of the adrenal glands. When you have adrenal adenoma, hyperplasia, carcinoma, whichever side has this carcinoma, adenoma, hyperplasia will be enlarged. Other side is going to be small. Okay. With the ACTH secreting pituitary adenoma, meaning you have increase in ACTH coming from the pituitary gland, okay, due to adenoma being there, which is known as Cushing disease, is going to enlarge both glands equally. Same thing goes for the paraneoplastic ACTH secretion, which is going to come from small cell lung cancer and bronchial carcinoids. Because they're secreting ACTH, they are going to cause bilateral equal enlargement of adrenal glands. Okay, so here if you see, we have a total different thing, total different. You can right away tell, but here these two are same, and we will differentiate that later on with the diagnosis. How do we differentiate between two? We will talk about that in a bit. But here are the findings. So let's look at the findings now. The findings are moon phases. An important thing. Cortisol is going to give you high cortisol. Cushing syndrome is going to give you moon phases. Okay, what are they? They are the metabolic syndrome, which is your hypertension, hyperglycemia, and hyperlipidemia. Again, if you recall, it increases your alpha-1 receptors, right? So cortisol increases alpha-1 receptors on arterioles. So when you increase the alpha-1 receptors on arterioles, your norepinephrine and epinephrine would have increased effect on these receptors, right? Causing vasoconstriction, leading to hypertension. What is metabolic syndrome? Hypertension, hyperglycemia. Why hyperglycemia? Cortisol, and with the rest of the other hormone, which I talked about like a million times by now, they're all counter-regulatory hormones. All they want to do is get the glucose into the bloodstream from anywhere, causing gluconeogenesis, glycogenolysis, glycolysis, everything. They want to do every single thing to have that glucose in the blood, leading to hyperglycemia, hyperlipidemias. Okay, and this whole thing is known as metabolic syndrome. Then you have obesity, truncal weight gain with wasting of extremities. Okay, round moon faces. Picture A, you can see round moon faces, and dorsal cervical fat pad on the back side. You will have dorsal cervical fat pad on the neck, which is called as buffalo hump. Okay, that is going to be there. On top of that, you will have osteoporosis. And why, the question is, why would you have osteoporosis in these patients? Because because you are decreasing osteoporosis by decreasing the osteoblasts, decreasing osteoblast. So when you decrease osteoblast due to the fact that you increase in cortisol, you are going into osteoporosis because osteoblasts are the bone forming cells. Okay. Neuropsychiatric disturbances are going to be depression, anxiety, irritability. Facial plethora is there. Okay. With facial plethora, what else you can think of? You have androgen axis. Androgen axis is going to cause acne, hirsutism. These are your sex hormones, right? They will cause acne, hirsutism. Okay. And then you have cataracts, immunosuppression. Immunosuppression, cortisols, they suppress immune systems by, if you recall, they inhibit phospholipase A2, right? They also inhibit IL-2. They also inhibit histamine. Only thing they're going to cause increase in, I think it was neutrophils, because they stopped adhesion. So neutrophilia, everything is just penia. Okay. Immunosuppression, ecchymosis, which is easy bruising. Okay. And you have skin changes, for example, thinning, stria, hyperpigmentation. And why would you have these stria and skin thinning? Well, due to the fact that you have, when you have decrease due to impaired, so they, wait, let me just write this down. This is important. Stria, because when you have decreased, impaired, let's say decreased or impaired collagen synthesis, they cause decrease in collagen synthesis in the vessels, and that, when you decrease collagen synthesis in vessels, the vessels will break, leading to formation of these strias, as you can see in this picture. Okay. And that would also lead to easy bruisability, so ecchymosis. Okay. And that is one thing they haven't mentioned is, with easy bruisability and decreased collagen synthesis, there's a decrease in wound healing. Okay. So let's okay, one last thing here, and then I'll see some details here. Now with hyperpigmentation, because you know that you get hyperpigmentation whenever you have increased level of ACTH. ACTH comes from POMC. That POMC, if you recall, is giving off your ACTH. And if you don't know what I'm talking about, then again, go back to your, I guess it's the second page. POMC gives rise to ACTH, MSH, which is your melanocyte synthesis hormone or secreting hormone. And then you have the other thing, you have the endorphin, beta endorphins. But this MSH, melanocyte secretory hormone and synthesis hormone, is going to cause increase in melanin production that causes hyperpigmentation. And that is why you will see hyperpigmentation. Okay. Okay, so let's talk a little more on these symptoms. On top of all of this, you will also see increase in muscle wasting, because this is cortisol. It tries to put all that. It leads to increase in proteolysis. When you break down that protein, you are going to cause muscle wasting, right? And why is it causing muscle wasting? Because it wants the gluconeogenesis to work so that it can put all that glucose into the blood. All right. And importantly, it's going to cause proximal muscle weakness, because you're losing that muscle. You're going to cause proximal muscle weakness. That is why you have thin extremities. Where did they mention thin extremities? obesity, truncal weight gain, here you go, wasting of extremities, thin extremities. That is the reason why you have thin extremities, because you are losing the muscle. And not only you will have thin extremities, but on top of that, the most important thing is, in the question stem, they're not going to say thin extremities. They'll say, okay, the patient can't climb stairs, or difficulty. There's a difficulty to climb stairs. It's hard for them to stand after sitting. So it's hard for them to stand from sitting position. Okay. And all of this is due to the fact that you have proximal muscle weakness, high yield. Okay. Okay. Other than that, you are going to see, let's just write it here. Obesity is due to the fact that you have fat redistribution due to increase fat redistribution. It is due to increased insulin, due to increased glucose. Okay. And central android obesity will be seen. Increase in abdominal fat and thin extremities, which is basically saying, again here, obesity, trunk. So increase in abdominal fat and thin extremities. We talked about that one. Let me see if there is anything extra. Okay. So with that, I think, yeah, let's okay. So what did we talk about? What are the things? So you got to know a couple of features. Metabolic syndrome, okay, one thing. Obesity, second thing. Third thing you will have is osteoporosis. Fourth thing, neuropsychiatric problem. Facial plethora. Okay, high yield is this. Androgen axis. High yield. Androgen axis. Okay, and then you have cataracts, immunosuppression, ecchymosis, skin changes, and then muscle weakness, proximal muscle weakness. Neuropsychiatric, just think about neuropsychiatric being, there's a range from decrease in concentration to psychosis. So from depression, anxiety, irritability, there's a decreased concentration to psychosis. That's also one of the things. Okay. With this, I guess we got everything here. Okay, let's talk about last thing here. For the top, something Cushing syndrome, ACT dependent. Okay, so let's just say Cushing syndrome, ACTH dependent, and ACTH independent Cushing syndrome. ACTH dependent one is the Cushing disease, and your ectopic ACTH. An independent one is going to be your adrenal adenoma carcinoma. So what did I write here? Cushing syndrome depends upon ACTH, right? If it depends upon ACTH, either it is the Cushing disease, meaning it is coming from the pituitary gland, or it is the ectopic secretion. If it is independent, that means it does not even depend on ACTH, then it is itself, it has a problem. The three causes are just out. The last cause is just the exogenous coming from outside. Okay. with that, let's go with diagnosis. Okay, let's talk about now the diagnosis. In the diagnosis, screening tests include increase in free cortisol on 24 hours urinalysis. So you will see increase in free cortisol on the 24 hours of urinalysis, or increase late night salivary gland cortisol, meaning in the saliva you have increased amount of cortisol, and there is no suppression with overnight low dose dexamethasone test. Okay, simple as that. So all you have is the simplest one that you look for is your increased late night salivary cortisol, and you have no suppression with overnight. You don't suppress with overnight low dose dexamethasone test. So let's read this here. So what do we have? So first of all, we have to establish, what do we have to establish? That there is increased cortisol, right? So to establish we have increased cortisol, we either do 24 hours urine-free cortisol, or we check the late night salivary gland cortisol. Again, if you think about the normally the cortisol should be very high just before when you wake up. Okay. Here you have high at the late night salivary cortisol and are inadequate. That's second thing. Third thing is you have inadequate suppression on the low dose dexamethasone test. Okay, so this just essentially establishes that we have increase in cortisol, right? With that, what we have is then once we do figure out that we have increase in cortisol, then what do we check for? We look at the ACTH level, that either this cortisol is coming from outside, either it's coming from the problem in the pituitary gland, either it is coming from itself, which is the adrenal gland. So we have to see all that difference, right? To look for that, we look for ACTH. So let's look at when we measure the ACTH, measure serum ACTH, right? We are trying to establish the cause now, cause for high cortisol. So if it is suppressed, if you measure the ACTH and it is suppressed, which means it is decreased in ACTH, then we say, okay, whatever the cortisol was coming, it's coming. Look here, ACTH independent Cushing syndrome, that is not dependent on ACTH, because ACTH is suppressed. Still, we have high cortisol. So it is not from ACTH. So it is either that you're taking this cortisol from outside, or you have the problem itself off the cortisol, off the adrenals. So you have exogenously taking, or you have a problem within the tumor. Again, it's a very simple thing. Let me read one more time, okay? First of all, you have to establish that you have increase in cortisol, which is through this, okay? Once you do establish that there is cortisol, and the way you are going to establish is they will put this here, but they will also mention all these sign symptoms. So you will say, okay, hey, there is increase in cortisol, simple. When you already have increase in cortisol, then you say, okay, let's look at this ACTH level. If they are suppressed, if the ACTH is suppressed, it's not even there. Let's just say decrease ACTH on this side. When the ACTH is low and you have increase in cortisol, that means that this cortisol, let's just say increase in cortisol, that this cortisol is coming from outside or within the adrenals, which is adrenal tumor. So how can we check that? Well, first, then we have to do adrenal CT to confirm, or ask the patient, hey, did you take anything from outside? And also confirm with the adrenal CT. Now, if the ACTH is elevated and you have increase in cortisol, an increase in ACTH, that means that ACTH is causing the stimulation of the cortisol, and that's why we have the increase in cortisol. Simple, right? Then we go for high dose dexamethasone suppression test. When we give a patient high dose dexamethasone suppression test, If the ACTH is coming from top, which is anterior pituitary, that would suppress it because that's just an adenoma. But if it is a paraneoplastic disease, which is a carcinoma like small cell lung cancer or your carcinoid cancers, it will not suppress those because it's a carcinoma. Carcinoma doesn't get suppressed if you give something from outside, right? So high dose dexamethasone suppression test. If once you give this high dose dexamethasone, if ACTH decreases, then you call it Cushing disease. And again, what was Cushing disease? You have Cushing disease is when you have a pituitary adenoma, which causes the secretion of ACTH. So you give this high dose drug, it's going to inhibit ACTH secretion. You call it Cushing disease. And then you check on the MRI of the pituitary to identify the lesion, which is the adenoma. Okay. But you give the patient high dose dexamethasone test, still there is no decrease in ACTH. Then you say, hey, this must be some carcinoma. The carcinoma is ectopic ACTH secretion, which are we've seen up top, which are only two ectopic places, either the small cell lung cancer or the bronchial carcinoids. Okay. So ectopic ACTH secretion, and for that, then you go for, because we were talking about lung and carcinoid, you check everything: chest, abdomen, pelvis, to identify that tumor. Okay, so this is with the high dose dexamethasone test. Now there is something CRH stimulation test. What was CRH? Can you recall? If you were saying corticotropin releasing hormone, then you're absolutely right, which comes from hypothalamus. The CRH comes from hypothalamus, goes on anterior pituitary, and stimulates anterior pituitary to release ACTH, right? So CRH, we are giving CRH from outside. And that CRH, when this CRH goes on anterior pituitary, normally it will stimulate and release the ACTH. Here's the same thing. When we give CRH from outside, it's going to increase that ACTH, and then we can say, okay, this is Cushing disease, meaning it is responding. Whatever is responding. So just imagine this thing. Anterior pituitary is going to respond to everything, whatever you get from outside. It could be your high dose dexamethasone test, or it could be your CRH stimulation test. Anterior pituitary is going to respond. There is no way the anterior pituitary is not going to respond, okay? But your carcinoma, your tumor, your paraneoplastic ACTH secretion will not respond to both the things. Neither is going to respond to your dexamethasone, nor is going to respond to your CRH. Simple as that. Okay. So with that, look at this, the other one. Okay. We give CRH, Cushing disease, which is your pituitary adenoma, does respond, increases ACTH secretion. And then you do MRI to check up the brain. You give CRH, ACTH, there is no increase in ACTH level because your ectopic ACTH, which is your paraneoplastic small cell lung cancer, bronchial carcinoid, it is not going to respond. So there is no increase in ACTH. And then you check for CT of the chest, abdomen, pelvis. Again, everything: chest, abdomen, pelvis, to identify the tumor. Hope that makes sense. With that, we are done with Cushing's. Cushing's are no high yield, okay. I guess there is no need for a revision of this part because this is very easy. Understandable, right? So yeah, let's just take a break and let's get back after 10 minutes. I'm going to put up the timer. Or we can make a 5 minutes break. How about that? Let me put the timer for 5 minutes. 5 minutes. Okay, welcome back, guys. Uh, okay, so I have a question here. Facial plethora. Okay, let me uh, write it here. So again, here's simple thing. Where's facial plethora? Here. Facial plethora is again due to the fact that you're increasing the alpha 1 receptors, right, causing hypertension. When you have increase in blood that causes facial plethora, with the glucocorticoids being there. Uh, Cortisol is a glucocorticoid, increases glucose. When you increase glucose, that's going to cause cataract formation. Okay, so that's what we have. Okay, since we are here, let's also talk about one extra thing. Is about the labs, okay, which is also essential. So one extra thing here is about the labs. Let me write it here. In the cushions, you will have these lab values. With all of them are here, but on top of this, you will also have low potassium. Okay, let's just keep it here. So you have increased sodium levels, decrease in potassium levels. Okay, and when you decrease the potassium and you're decreasing hydrogen ions, you are decreasing hydrogen ions will cause metabolic alkalosis. And metabolic alkalosis, you also have, so all of these functions, these extra labs that I'm just mentioning here, they are all due to the fact that when you stimulate your adrenal cortex, you're stimulating all the hormones, right? So you're not only you're stimulating your cortisol, but you're also stimulating your aldosterone, you're stimulating your cortisol, and you're stimulating your sex hormones. So all of them are going to be there. For example, like androgens, right? So androgens, we are seeing androgenic excess causing acne, hirsutism, all that, right? With the cortisol, we're seeing all these symptoms, but with the aldosterone, we will also see increase in sodium, decrease in potassium, decrease in hydrogen ions. That is going to cause metabolic alkalosis. Let me erase this part. Metabolic alkalosis, because you're losing your hydrogens, causing alkalosis. Okay, and and also you're also going to cause increase in bicarb reabsorption. Okay, with the just because of aldosterone. Okay, and that is all for, so these are the extra labs that you will see with cushions. Okay, with that, let's move on to the next thing. Then we have adrenal insufficiency. As the name suggests, you have adrenal insufficiency. There is inability of the adrenal gland to generate enough glucocorticoids, plus minus. So again, glucocorticoid is your cortisol, mineralocorticoid is your aldosterone for the body's need, right? It could be acute or chronic. Symptoms include weakness, fatigue, orthostatic high yield, orthostatic hypotension. Orthostatic hypotension will be there due to the fact that, again, your cortisol was the one which was trying to have some tone for the vessel by increasing your alpha 1 receptors. When you don't have cortisol, you don't have alpha 1 receptors, you are going to cause essentially hypotension. Okay, muscle aches, weight loss, GI disturbances, sugar or salt craving, again, high yield. These patients are going into sugar or salt cravings. Okay, and again, what is this thing? It's adrenal insufficiency. The adrenals cannot make enough cortisol or aldosterone. Okay, with that, let's look at the treatment. Treatment is simple. When they cannot make it, give it from outside. Either if the glucocorticoid, which is cortisol deficient, give glucocorticoid. Aldosterone deficient, give mineralocorticoid. Replace them, right? Now let's talk about primary, secondary, and tertiary adrenal insufficiency. So the primary, as the name suggests, is going to be your primary adrenal gland being affected. You have a decrease in gland function, right? When the gland is not functioning, it's going to have low cortisol, low aldosterone, and so with the low cortisol, low aldosterone, what are you going to get? Hypotension, hyponatremic volume contraction, hyperkalemia, metabolic acidosis, uh, skin mucosal pressure areas, and buccal mucosa. Okay, so why are we having all these symptoms? For that, we have to look again, we have to go back to the normal aldosterone. What is aldosterone doing normally? So it's going to reabsorb sodium, it's going to dump potassium, and it's going to dump your hydrogen ions, right? And with that, when you dump the hydrogen ions, and it's going to cause metabolic alkalosis, and this is normal. Normally, aldosterone is doing this, right? Causing metabolic alkalosis. Now, when we don't have the normal, when we have low aldosterone, you will lose your sodium. So low sodium, meaning hyponatremia, increased potassium, meaning hyperkalemia, and you're not going to dump your hydrogen ions, which are acid, leading to metabolic alkalemia. So you're going to keep this because you are deficient in your aldosterone, so it's going to cause acidosis, so metabolic acidosis. Okay. Other than that, let's also talk about now the cortisol. So because we have low cortisol here, that's going to show up as decreased cortisol. First of all, you have hypotension. I mentioned that one. Hypotension, hypoglycemia, hypoglycemia. Because you can recall yourself that it takes a glucose, puts it into the bloodstream. Now it's not there, so it's going to cause hypoglycemia. Important thing, right? Other than that, you will have, importantly, with low cortisol, you are going to have eosinophilia. Okay, and you will also have anemia, and that anemia is going to be your normocytic normochromic anemia. So normocytic normochromic anemia. And with this, two extra things are going to be, because you are going into hypotension, so you can go into shock, and also you're going to have hypopigmentation because you don't even have you don't have the cortisol. Well, my bad. It's because you have low cortisol, it's going to be hyperpigmentation. And then let me tell you how. Hyperpigmentation. And why is that? Because when you have low cortisol, the ACTH is from the anterior pituitary, the ACTH will come down. First of all, your hypothalamus, right? Hypothalamus is going to secrete your CRH. CRH is going to stimulate your POMC. POMC will release your ACTH, your MSH, everything, leading to hyperpigmentation. So with low cortisol, you have hyperpigmentation. Okay. And these are the functions specific to each hormones. And that is mentioned also here. Hyperpigmentation, you can see in the picture, hyperpigmentation. Okay. And then you have decrease in cortisol leads to decrease in negative feedback effect on pituitary, increased production of POMC derivatives, which are beta endorphin, ACTH, and MSH, cause an increase in melanin synthesis due to increase in MSH, primary pigments, the skin and mucosa. Okay, they're saying primarily it's the primary pigments are going to be seen in the skin and the mucosa. So you can see on the mucosa, if I zoom in, you can see the blackish hyperpigmentations, and also the skin is also hyperpigmented, right? With that, let's look at now something known as Addison's disease. In the Addison's disease, it's the chronic primary. So primary adrenal insufficiency is acute and chronic. Acutely, it's going to decrease in gland function, or chronically, it's going to decrease in gland function, which is adrenal insufficiency. If it happens chronically, the question is, why would something happen chronically? Well, it is caused by if you go into adrenal atrophy or destruction. then slowly and gradually it's going to go into insufficiency if you have atrophy or destruction. Most common question is, why do you have atrophy or destruction? Well, due to autoimmune adrenalitis. It's an autoimmune disease. Okay, high income countries have autoimmune destruction of the adrenals, or the low income have the tuberculosis, TB, causing the adrenal insufficiency, which is also very high yield. Okay, that is going to be there. What else? With the autoimmune adrenalitis, you will see that the patient with pre-existing, so the patient will have pre-existing history of autoimmune disease, okay? Pre-existing history will be there. Another thing is called metastatic carcinoma. Let's just also mention that. Tuberculosis is one. Then you have the metastatic carcinoma. Okay, metastatic carcinoma is the lung cancer. So remember, the lung cancer, they love to go to adrenals. So lung cancer goes into adrenals and causes Addison's disease by chronically, slowly and gradually causing destruction of the adrenal gland, leading to adrenal insufficiency. So lung cancer leading to going to adrenals, okay? That's the metastatic carcinoma. Okay, so we talked about 3 causes again. The first is autoimmune, which is in high income countries. Then you have tuberculosis, low income countries, and then you have the metastatic cancer. Which cancer? Lung cancer specifically goes for the adrenals. With this, yeah, we are pretty much done with the Addison's disease. Let's look at the next thing. What do we have? Is the secondary and tertiary. So we have secondary, then we have tertiary adrenal insufficiency. So let's talk about each one of them. So here we have decreased pituitary. Secondary means it's not the primary organ being involved, meaning the adrenal is not involved. Something else is, which is causing the adrenals to go into insufficiency, right? So here we have decrease in pituitary ACTH secretion. The pituitary is not secreting ACTH, that is the problem. Or there is a decrease in CRH secretion from a hypothalamus, and that's the tertiary problem. Secondary, again, if you recall the axis, how things work, you have hypothalamus, which secretes your CRH on the anterior pituitary, which then secretes POMC, which is POMC. One of the derivatives of POMC is ACTH, right? And also, always think about MSH here. Okay. Now, if you have a problem here that the anterior pituitary is not secreting ACTH, you call it secondary. And if you have a problem here, you call it tertiary. So which one was primary? That's actually right, the full axis. So it makes sense. So ACTH goes on the adrenal gland. These are our adrenal glands, right? Let's just say adrenal. Okay. When ACTH goes to adrenal gland, the adrenal gland then secretes cortisol. Okay. If you have a problem within the adrenals, that's going to be your primary adrenal insufficiency. You have a problem within the anterior pituitary, it's going to be your secondary adrenal insufficiency. And if you have a problem in the hypothalamus in the CRH synthesis, that's going to be your tertiary adrenal insufficiency. Hope this makes sense. With that, let's move on. Then you have the no hyperkalemia. We will not see hyperkalemia. Why? Because aldosterone synthesis is preserved due to functioning adrenal gland. So in the secondary and tertiary, where's the problem? The problem is here, and we're not getting ACTH, right? But adrenals are all normal. And if you recall your GFR, granulosa fasciculata and reticularis, granulosa didn't even need ACTH, right, for the aldosterone to be secreted. All granulosa needed was angiotensin II coming from the RAS, renin-angiotensin system, right? So granulosa will be there, and granulosa will secrete aldosterone. So aldosterone is normal. When aldosterone is normal, you will not see hyperkalemia. In fact, what you will see is hypokalemia. Opposite, right? But remember, no hyperkalemia, important. And I'll tell you the differences in a bit, but let's just read it here. Aldosterone synthesis preserved due to functioning adrenal gland because of intact RAS. No hyperpigmentation. No hyperpigmentation. No hyperpigmentation because in the primary and secondary, you're not even making ACTH. You're not even going and stimulating ACTH, right? Why would you have hyperpigmentation? So two things differentiate primary versus secondary and tertiary. And those are these two, hyperkalemia, hyperpigmentation. They're not going to be seen there. Okay, secondary adrenal insufficiency. Now we're talking about this secondary adrenal insufficiency, just in this part here where the ACTH comes from the pituitary. So it is due to pituitary pathologies. Yeah, I mean, wow. And they're telling us something very good. Wow. For sure it is pituitary, man. Come on. You have to mention this part. But okay, anyways, this is coming from pituitary. For sure it's a pituitary problem. Okay. The tertiary insufficiency is most commonly due to abrupt cessation. Okay, now this is important. Now the tertiary adrenal insufficiency is most commonly due to abrupt cessation of chronic glucocorticoid therapy, HPA access. Tertiary is from treatment. Wow, that's just amazing. Now let me no matter how much emphasis I put here, this is still going to be very low. Okay. Okay. I mean, this emphasis was given to me by my pathology teacher. I mean, and still I don't forget it. So whenever you're giving a patient glucocorticoid, okay, you always have to taper them off. Always have to taper them off. Tapering means if you are giving, let's say, dosage 20, you slowly go down to a point where it's barely minimum. Okay, and why is that important? Because when you give someone glucocorticoid from outside, it suppresses their HPA axis, which is all of this that I mentioned here. This HPA, hypothalamus pituitary adrenal axis, whole thing gets suppressed, and the body just relies on whatever you're giving from outside. So if you were to abruptly stop this 20 milligrams, I mean, for sure 20 milligrams is low dosage, but more than that, 100 milligrams, let's say, what's going to happen is your body will not recover it, and your adrenals will go into adrenal insufficiency, and then there's just destruction of adrenals. They will not make the hormones anymore. Okay, and then you are left with what? Low cortisol, and cortisol is essential for life because it keeps the vessel in a tone of the vessels, which is required for the blood pressure to be there, right? So again, glucocorticoid, chronically you're giving glucocorticoid therapy. You're giving a steroid from outside. You have to taper it off. The reason being, if you do not taper it off, the body will go into adrenal insufficiency. And here is the book. Let's read this one now. Due to abrupt cessation right away you stop glucocorticoids. No way, Jose. Okay, can't do it. Don't do it. And also, please tell the patients don't do it. Sometimes patients stop it. Okay, they can't take like 7 drugs in one day, and then next day they take 6 drugs. Next day they 5 drugs, 4 drugs, 3 drugs. They say, hey, screw it, can't do it. But you got to tell them, hey, if you don't do it, then your adrenals are going to go into insufficiency, and it's a bigger problem than you came with. Okay, so please cooperate with us. Okay, simple. Getting back here on the topic, we have the chronic glucocorticoid therapy. We do not abruptly cessation of, we do not abruptly cessate the adrenal corticoid. Not abruptly. What do? We taper them off. Simple. Okay. Why? Because we don't want to suppress this HPA axis. HPA axis. Okay, so again, tertiary is from treatment. So someone, let's just say example, someone would abruptly stop the glucocorticoid therapy. When you abruptly stop the glucocorticoid therapy, what's going to happen is you are going to go into tertiary adrenal insufficiency, in which case that you are not even making CRH anymore. Okay, there is insufficiency. When the CRH is not going to go down and stimulate ACTH, you're not going to make ACTH. When ACTH is not there, you're not going to make cortisol. Simple as that. Okay, so mnemonic is pretty good here. Tertiary is treatment. With that, I think we did a pretty detailed job here. So let's move on with the next part. That is going to be your adrenal acute adrenal insufficiency. What is going on with my eraser? Okay, let's take a look at acute adrenal insufficiency, also called adrenal Addisonian crisis. Adrenal crisis or Addisonian crisis. Do not mix this with Addison disease, which is chronic primary adrenal insufficiency. This is, look, Addisonian. Okay, Addisonian crisis, disease, adrenal crisis. That is what's called acute. And here, this is chronic. Okay, often precipitated by acute stressor. What is acute stressor? That increases, that there's increased glucocorticoids, increase in glucocorticoids, glucocorticoid requirements, example, infection. You have acute stressor, could be anything, infection, we talked about it, infection, surgery, trauma, anything is there that's going to increase. That's the acute stressor. So in stress, you need the stress hormone. What is your stress hormone? Cortisol. What is cortisol? Cortisol is glucocorticoid, right? You need that, right? So in patients, when you have stress, but in patients when they are going into acute stress, but they have pre-existing adrenal insufficiency, or they are on glucocorticoid therapy, meaning they're taking glucose from not glucose but cortisol, glucocorticoid from outside, or either that, or either their adrenal insufficiency already is present in them. What's going to happen to those patients? Well, they are going to cause adrenal crisis, which is acutely failure of the adrenal glands, which is adrenal insufficiency. Well, question is, why does this happen? Well, it happened because this is very high yield and important. We said acute stressor, right? And I said acute stress could be a surgery. So again, if someone is taking glucocorticoids and they're going for surgery, you bump their cortisol up. Because normal physiologically, if you're not giving them glucocorticoid, normal physiological action of their body would be that the body will produce increase in cortisol. So when you're giving glucocorticoid and you are suppressing the HPA axis, and the body's like, hey, relieved, we are getting something from outside, and now they're going to increase in stress, they need more cortisol, which normally they would have gotten if you're not suppressing their HPA axis by giving outside glucocorticoid. Again, my bad for saying glucose, but it's a glucocorticoid. Again, simple thing. Let's make things simple, and that is that when you are going in surgery is a stressor. Trauma, surgery, infection, all these are acute stressors. Normal physiologically, your body increases glucocorticoid, which is also known as a stress hormone. Okay, normally body increases it, but if you're giving a patient a glucocorticoid therapy, let's say 40 milligrams from outside, you're giving this patient a glucocorticoid continuous therapy, and the patient is going through infection, surgery, trauma, anything, and you do not increase your dosage, they are going to go into adrenal crisis because they require more cortisol than what you are giving them. Okay, and it's going to present with acute abdominal pain, nausea, vomiting, high yield, altered mental status, high yield shock. Why shock? Because again, alpha 1 receptors are needed for the vessel's tone. When you do not have enough cortisol, what's going to happen is you are not going to have this tone, it's going to cause hypotension. Hypotension, and hypotension will lead to shock, right? And also alter mental status. The patient is undergone surgery, comes back, everything normal. After a couple of days, the patient is going into altered mental status. Must think about glucocorticoid. Do they have two questions? Either were they already on glucocorticoid therapy, or are they? Is there any pre-existing adrenal insufficiency? In either the cases, give cortisol simple. Okay. Now there is something called Waterhouse Friderichsen syndrome. This is bilateral adrenal hemorrhage. Both adrenals are going into hemorrhage in the setting of sepsis. Example, meningococci leading to acute primary adrenal insufficiency. So the question arises is how is this going on? So meningococcemia, which is meningitis, right? Meningitis. So let's talk about this. Neisseria meningitis will cause meningococcemia, which is meningococcal septicemia, which is essentially sepsis. So let's just put simply sepsis. Neisseria meningitis causes sepsis. That septicemia or sepsis is going to cause DIC, disseminated intravascular coagulation, right? And that DIC, again, the hallmark of DIC is going to be you have low platelets, you will have petechial hemorrhages, and oozing, very high yield oozing from IV sites. Oozing from IV sites. Okay, DIC. Sepsis leading to DIC. That DIC is going to cause shock, right? And that shock will lead to low sodium, high potassium, decrease in glucose due to the fact that you have low cortisol from the adrenal insufficiency. Okay, and this shock will eventually lead to death. Okay, so with this, let's just review this part and move on to the next one. Okay, for Waterhouse-Friderichsen syndrome, all you're going to think about someone having a Neisseria meningitis infection, which causes septicemia, which causes DIC, shock, death, and that would lead to adrenal hemorrhage and necrosis. Okay, so bilateral hemorrhage and necrosis in settings of sepsis, leading to primary adrenal insufficiency. So again, here we talked about primary adrenal insufficiency, three things. We said either the patient is on glucocorticoid therapy, either there is a pre-existing adrenal insufficiency, or there is an infection, meningococcemia, which is due to your Neisseria meningitis, causing sepsis, DIC, and shock, leading to hemorrhage in the bilateral adrenal glands. Okay, with that, let's look at the last one here, which is concern for an adrenal insufficiency. If you are concerned for adrenal insufficiency, you check the AM cortisol or ACT stimulation. If there is decreased AM cortisol and or decrease in peak cortisol on stimulation test, then you check the measure. So this basically tells us that there is decreased cortisol, right? When you have decreased cortisol, then you say, hey, is this cortisol coming that the adrenals are not making, or there's a pituitary problem or hypothalamus problem, right? So then you check ACTH levels. If the ACTH levels are high and still you have ACTH is high, my bad, not low, but high. ACTH is high and still you have low cortisol, then you say adrenals have the problem. You call it primary adrenal insufficiency, right? But if you look at the ACTH level, they are normal or low. Again, what do we have? We have low cortisol here. This is what I'll tell us. Then we have low cortisol. And we check the ACTH either low or normal. That means that this is due to the fact that you have a problem in the ACTH. So low ACTH would be a problem in the pituitary, and a normal ACTH would be a problem in the hypothalamus or primary and secondary and tertiary insufficiency. With that, we are done with adrenal insufficiency. Okay, let's take a break and we'll back and do the next one, which is hyperaldosteronism. Let me put up the timer. Okay, welcome back, guys. Let's get started. Okay, there is a question now. Okay, yeah. So again, think about the cortisol as the cortisol. Normally, is the cortisol. What does it do? It inhibits your immune mediators, right? All the immune system cells, everything. And normally, the cortisol also job is not only to inhibit immune things but also to keep the mass of RBCs, to have the mass of the RBC. When you have a low cortisol, it's going to decrease the total RBC mass, and that is going to be seen as your anemia. And also, it does interfere with the iron as well. But here, iron is not going to be that much deficient. That's why you will have normochromic, normocytic anemia. But this is of a sort of a little clinical tie-in type of thing, you might not see it anywhere much, but they do, like, sometimes put in the question, and you're like, why is this? So I just explained so that you might have a clue when you do take a look at those sort of questions. Okay, with that, let's move on with the next one. Okay, here we go. Now let's talk about hyperaldosteronism, which is increase in aldosterone, right? So increased secretion of aldosterone from where? Adrenal glands. Clinical features include hypertension. Again, what are the normal functions of aldosterone? Whatever the normal is, there's going to be hyper functioning aldosterone. So hypertension because of sodium retention, right? Uh, Decrease or normal potassium. Normally you wanted to throw out potassium, so you're going to have a low potassium. Metabolic alkalosis, yeah, you're going to have metabolic alkalosis because you're also throwing out hydrogen ions, leading to metabolic alkalosis, right? Primary hyperaldosteronism does not directly cause edema due to the aldosterone escape mechanism. However, secondary cause of hyperaldosteronism, example, heart failure, impairs the aldosterone escape mechanism, leading to worsening of edema. Okay. What is your aldosterone escape mechanism now? So let's just write this down here. So when you have increase in aldosterone, no matter which cause it is coming from, it is coming from itself, the adrenal hyperplasia or hyperfunctioning adrenal adenoma, essentially is causing increase in aldosterone. That aldosterone goes to the kidney, stimulates the kidney, right? To do what? To do a couple things. Increase in potassium, my bad, not increase, but it's going to decrease potassium reabsorption, which means essentially means throwing out that potassium, which leads to, in blood, what you are going to see is called hypokalemia, low potassium. Okay, you're also going to dump out that hydrogen ion, which is going to cause metabolic alkalosis, right? And then you are reabsorbing sodium. When you reabsorb sodium, you are essentially causing blood increase in blood volume. That increased blood volume will cause hypertension, right? And that hypertension, now when you are in hypertension, now what's going to happen is that your renin, so a couple things. Wait, let's just have two things here. Your hypertension is going to cause decrease in renin release, and that renin will decrease your angiotensin 2 activation. So decrease in renin and decrease in angiotensin 2, right? With that hypertension. On top of that, because you have hypertension, right, you're also causing, I don't know if you can see it. I'll try, let me just do a bigger font here. Bigger. So with hypertension, you're going to cause increase in the renal blood flow, right? An increase in renal blood flow, increasing GFR, glomerular filtration rate, and that essentially all of that is going to cause uh, increased excretion of sodium, right? Because more sodium is going to go there, and because you are already having increase in blood volume, you are going to deplete out that sodium. So increase sodium excretion in urine. And not only that, but also increase in blood volume causes what? Again, it's going to dilate the ventricles, atria and ventricles, causing increase in ANP, right? And that is going to also cause the same thing, which is sodium excretion. When you excrete that sodium, it's going to limit the edema. So again, this is the aldosterone. So this specifically, this sodium excretion, due to the fact that a lot of blood is going, because of hypertension, you have increased renal blood flow, increase in GFR, and an increase in ANP. All of this will cause aldosterone escape mechanism, escape mechanism, in which you're essentially limiting edema and limiting hypernatremia. Hypernatremia basically means increase in sodium levels, and this is aldosterone escape mechanism. And this mechanism is going to cause what? Because there is excreting the sodium out, is going to cause normalization, normal sodium levels, and which will not cause edema. Simple as that. So with that, let me erase all this part, and let's read the book here. Okay. So here, again, we said the primary hyperaldosteronism does not directly cause edema due to aldosterone escape. And why doesn't it cause edema? Because it's excreting sodium. And why is it excreting sodium? Due to the fact that you have increased GFR, increase in renal blood flow, and increase in ANP, all of which are causing increase in sodium excretion. Okay, so no edema with the primary aldosterone, but secondary aldosteronism, example, if you have a heart failure, impairs the aldosterone escape mechanism, leading to worsening of edema. Okay, then you have this primary, let's talk about now the primary hyperaldosterone, increase in aldosterone, and secondary hyperaldosterone. So the primary one is seen in patients with bilateral adrenal hyperplasia. You have the adrenal hyperplasias or adenoma, which is known as Kahn syndrome. Okay, this is the primary, meaning the primary organ is affected. So primary, that's going to cause increase in aldosterone, decrease renin, high yield. Okay, primary, increase aldosterone, decrease renin, leads to treatment resistant hypertension. Treatment resistant hypertension, because no matter what treatment you're giving, you have increased aldosterone due to the fact that you have hyperplasia or adenoma, and they will keep secreting that aldosterone, will keep getting that sodium in, and it's going to keep that hypertension. No matter what treatment you give is a treatment-resistant hypertension, right? Now, the secondary hyperaldosteronism is due to the fact that it is seen in the renovascular hypertension or JG cells tumor, which are renin producing, and edema, cirrhosis, heart failure, nephrotic syndrome. So again, let's take a look at each one of them. With the renovascular hypertension, you have either the fibromuscular dysplasia in a young female, in which you have the aorta and you have the renal artery here. You have this fibromuscular dysplasia. That means to the kidney, that means you have a decreased blood going to the kidney, causing increase in renin secretion, right? Increase in renin secretion. Or you have a tumor that does itself, it's no matter, you have normal blood supply, but it's a tumor which is secreting renin. You are causing increased renin. That increased renin is essentially causing increase in aldosterone. So that is what's called secondary, because it is not aldosterone problem. It is the one who is activating aldosterone. Who is activating aldosterone? Your renin angiotensin aldosterone system, right? So your renin. So when you have increase in renin, it's stimulating your aldosterone, causing increase in aldosterone, and problem is here. in the renin. So what is the differentiating feature in both of them? That's your renin levels. Why? Because your aldosterone is high in both, but your renin is low in the primary, but high in the secondary hyperaldosteronism. Okay. I hope that makes sense. What else we can think of? So we talked about increased aldosterone, decreased renin, which is the Kahn syndrome, increased aldosterone, increased renin with secondary. And there's a third thing, which is not even mentioned here, that is going to be you have decreased aldosterone, decreased aldo, and decrease in renin. Well, that is seen in your non-aldosterone causes, meaning hyperaldosteronism causes, and those are going to be your congenital adrenal hyperplasia, congenitally adrenal hyperplasia, your Cushing syndrome, your exogenous mineralocorticoids. I think they will mention it up somewhere, and we will talk about these at that time. But right now, just remember hyperaldosteronism, primary, secondary. Primary means primary problem. Secondary means coming from the secondary cause. Okay. The causes are very important for the secondary. Think about renovascular disease. Think about malignant hypertension. Think about renin secreting tumor, JG cell tumor. Other things are going to be your diuretic use, and renovascular hypertension will cause renal artery stenosis, atherosclerosis in elderlies or in older men, young female, renovascular fibromuscular dysplasia. Okay, all of these the causes of secondary hypertension. Secondary hyperaldosteronism. Okay, for the primary one, the cause is going to be your primary tumor, adenoma, or hyperplasia. Okay, and that is all. And with the primary, you will see aldosterone escape, and with the secondary, you will not see aldosterone escape. Okay, and that's pretty much it. Moving on with the next one, we have the neuroendocrine tumors. Neuroendocrine tumors, as the name suggests, they're neuroendocrine origin. They're heterogeneous groups of neoplasms originating from, simple thing, neuroendocrine cells, which have traits similar to nerve cells. Again, name suggests neuroendocrine. So they are the nerve cells and the hormone producing cells. Simple, right? So why is that simple? And it's going because then you will have specific secretory products like chromogranin A, your NSE, which is your neuron specific enolase, synaptophysin, all of them. If you see it, then you can right away think about neuroendocrine tumors here, because they're coming from the nerve cells and they produce hormones of neuroendocrine. Most neoplasms occur in the GI system. For example, the carcinoid and the gastronoma. In the pancreas, insulinoma, gluconoma, and in the lungs, there's a small cell carcinoma. Look at all these neuroendocrine tumors: carcinoid, gastronoma, insulinoma, gluconoma, and small cell carcinoma. Also, the thyroid medullary carcinoma and adrenal pheochromocytoma. Wow, amazing. Neuroendocrine cells, example pancreatic beta cells, anochromophene cells, have a common biological function through amine precursors uptake decarboxylase. Despite difference in embryonic origins, anatomic site, and secretory products, which are chromogranin A, NSE, synaptophysin, serotonin, histamine, and calcitonin. Treatments are surgical resection, or you can give somatostatin analog. Somatostatin analog is octreotide, which is going to inhibit every single thing that is there. It inhibits all hormone secretions, right? And that is why that is the treatment. With that, one more thing you have to think about with pheochromocytoma and neuroblastoma, which is going to come up as well. Okay, let's talk about now the next one, which is neuroblastoma itself. Here we have, it's a solid extracranial neuroblastoma, extracranial tumor in children less than 4. Okay. Um, it usually arises in the medulla, adrenal medulla. Again, children has adrenal medulla tumor. It's called neuroblastoma, and we will see pheochromocytoma is also the medullary tumor, but seen in adults, which we'll talk about in a bit. But here, in a child of less than 4, you would have adrenal medulla problem, and it's called neuroblastoma. May occurs anywhere along the but it can arise anywhere against the sympathetic chain. Originates from neural crest cells, high yield NCC. So neural crest cells, if you recall, the neural crest cells, they are the ones which derive adrenal medulla, meaning adrenal medulla is derived from neural crest cells. Okay, so that is why when you have a tumor here, you say, okay, that is derivative of it originates from the neural crest cells. Okay, so most common presentation is abdominal distension, firm irregular mass that can cross midline, high yield, versus Wilms tumor, which is smooth and unilateral. Okay, Wilms tumor is smooth and unilateral, and we will talk about Wilms tumor later on. And this guy is going to be, it's going to cross the midline. And Wilms tumor is also seen in kids, and this one is also seen in kids. Okay, less likely to develop hypertension than with pheochromocytoma. Neuroblastoma is normotensive. That's very good mnemonic. Neuroblastoma is normotensive, can present with opsoclonus myoclonus syndrome, which is dancing eyes, dancing feet, high yield. Dancing eye, it's called OMS. OMS is dancing eyes, dancing feet. Okay, high yield. On top of the high yield point that you will see is increase in HVA and increase in VMA, which are catecholamines metabolites in urine. So HVA and VMA will be seen in urine. Again, high yield is going to be Homer-Wright rosettes, which are neuroblasts surrounded with central area of neutrophil. So if you look here, you have Homer-Wright rosettes. Homer-Wright rosettes with just so these are circular groups of dark tumor cells surrounded by pale neurofibrils. So they're surrounded by this pale neurofibrils. Okay. So dark tumor cells surrounded by pale neurofibrils. And these are the Homer-Wright rosettes, high yield. Okay. And then you have this characteristic of neuroblastoma and medulloblastoma. So Homer-Wright rosettes are not only seen in neuroblastoma, but also medulloblastoma as well. Bombesin high yield and NSE. NSE is from top. Bombesin is new here. So NSE and bombesin positive. Okay. Again, wait, let's look at what was medulloblastoma. It is most common, let me write here, most common brain tumor in child or in children, brain tumor in children. That's the medulloblastoma. And it most commonly involves the cerebellum. Okay, so both of them, medullo, and they have Homer-Wright rosettes, high yield, Homer-Wright rosettes. Okay, and then neuroblastoma is bombesin positive and NSE positive, associated with N-MYC oncogene. N-MYC oncogene gives us the poor prognosis. Okay. What else we can think of? Yeah, that's pretty much what we have. So let's just talk about these pathways, how we're getting HVA and VMA. Well, the way we get it is, let's just do the biochem here. So we have, if you recall, we have dopamine. Dopamine gets converted into eventually HVA. Simple. Dopamine gets converted into norepinephrine. Norepinephrine gets converted into your normetanephrines, normetanephrine by the enzyme COMT. Okay. And then normetanephrine will be converted into VMA, vinyl mandelic acid, by the enzyme MAO. There's an enzyme that works on norepinephrine that is called SAM. SAM will convert norepi into epi, and that epi, again, that COMT will work on it and make the same, but it's going to be, instead of normetanephrine, it's just going to be metanephrine. Those metanephrine will be again converted to the same metabolite, which is VMA, through the same enzyme known as MAO. Okay. Now, this is how we are getting HVA and VMA. HVA, VMAs. These are all catecholamine metabolites in urine. And why did I mention all this? Because it's going to show up in the next page or so when we talk about pheochromocytoma. Now let's see what is HVA. HVA is homovandelic acid. Let me write it down here. Homovandelic acid. And VMA is vinyl mandelic acid. Vinyl mandelic acid. Okay. With that, let's just review both of these. So the first thing we talk about is neuroendocrine tumors. Essentially, we are talking about everything that we are going to mention from this page onward, right? So we are talking about neoplasm of the GI, carcinoid, gastronoma, insulinoma, glucagonoma, small cell carcinoma, medullary carcinoma, and pheochromocytoma. All of them are neuroendocrine tumors, and they have a common biological function through amine precursor through which is taken up by the APUD, which is deoxycarboxylase, despite differences in their embryonic origin and atomic site and secreted products. One important thing is that in all of them you will see chromogranin A and SC synaptophysin. They will be secreting either serotonin, histamine, calcitonin, depending on which organ they're coming from. Treatment is surgically resect them, first thing, or try to give an octreotide, which is somatostatin analog, to inhibit the synthesis of all these hormones. Now we talk about neuroblastoma. It is a solid extracranial because it is in the adrenal medulla. That's why it's called extracranial. Which one is going to be intracranial? That is your medulloblastoma. Okay, it is seen in children of less than 4. It originates from NCC. It's going to shift from the midline versus Wilms, which will not, and it's going to cause less likely to cause hypertension than pheochromocytoma. So mnemonic neuroblastoma is normotensive. Can present with dancing eyes, dancing feet, with increase in the metabolites of catecholamines, increase in HVA, VMA, homorite rosettes will be seen, BOM be seen, and SE positive. NMIC gene is a poor prognosis. That's pretty much what we have for neuroblastoma. Moving on with the pheochromocytoma. Here for the pheochromocytoma, it is most common tumor of adrenal medulla in adults. What is the most common in children less than 4? It's going to be your neuroblastoma. So pheo adult. Okay. There's a red arrows point that shows us red arrow points to bone metastasis. So it goes and metastasizes in the bones. It is derived from chromogranin cells from the neural crest. Rare may be associated with germline mutation. So it is associated with germline mutation, for example, NF1, VHL, RET is MEN2A, 2B. Rule of 10 is also very high yield. 10% of these are malignant, 10% are bilateral, 10% are extra adrenal, meaning they are either, because you remember we talked about the previous one as well, that it can even run in the sympathetic chain. Okay, run along the sympathetic chain. So here's the same thing. They can run in the paraganglioma. Example are they can go into the bladder or the organ of Zucker, uh, Zuckergang. I thought it's a land, but it's not. Zucker candle. Okay. Then you can have 10% could calcify, and 10% can be seen in kids. Again, kids. Child is less than 4, but kids is more than 4. Then you have the symptoms that you are going to see, whether it's called is the most tumor secrete epinephrine, norepinephrine, dopamine, which we mentioned here. Dopa, norepi, epi, right? Which can cause high yield is episodic hypertension, recurrent episodic hypertension. Uh, Important is the word episodic, which they also might secrete EPO, erythropoietin, which can lead to polycythemia, increase in hematocrit, right? And symptoms occur in spells. Why spells? Because it is episodic. Relapse and remit, they come and go, right? That because it is episodic again. Um, so important point is going to be some clinical tie-in. That tie-in here is going to be in patients with undiagnosed pheochromocytoma. If you induce the patient with anesthesia, they can precipitate catecholamine surge, and which will cause hypertension crisis, flash papillary, not papillary, but pulmonary, flash pulmonary edema, and AFib, atrial fibrillation. Again, it's a very important clinical tie-in that you have an undiagnosed patient with pheochromocytoma, and you start the induction on that patient with anesthesia. That would precipitate the catecholamine surge, and that surge will cause hypertensive crisis, flash pulmonary edema and AFib, That's important, okay? That is why patients with red gene mutation, which is MEN2A, MEN2B, that is why patients with MEN2 should be screened for pheochromocytoma before they even go for surgery. Okay, so that is important clinical tie-in. Other than that, with the bladder wall, if the tumor is in the bladder wall, it's going to cause there's going to be signs and symptoms are going to be with the urination. When the patient urinates, they are going to have episodic headache because of episodic hypertension at that moment, right? Episodic headache because of hypertension, one thing. And if it is in the organ of Zuckercandle, very hard to tell, Zuckercandle, then you have it's basically at the inferior mesenteric aortic root. Where is this organ of Zuckercandle? That's the inferior mesenteric aortic root. Mesenteric aortic root. Okay. Now with this, important thing is going to be you would have episodic hyperadrenergic symptoms 5P, meaning increase in blood pressure, headache, respiration, which is essentially meaning increase in sweating, right? Palpitation, and pallor. Again, if you have catecholamine, a lot of catecholamines into the bloodstream, which will cause increased BP, which will lead to headache, increased sweating, tachycardia, and pallor. Okay, On top of this, just add one more P, which I don't know why they did not, which is polycythemia. So 6 P's essentially plus polycythemia due to the fact that they also secrete EPO. Okay. Then let's talk about now the findings. The findings are going to be that you have increase in catecholamine and metanephrines. Example, HVA, homovanillic acid, VMA, vinyl mandelic acid. In urine and plasma, episodic hyperglycemia may be uncommon finding. Episodic hyperglycemia, because again, when you have episodic increase in your catecholamines are counter-regulatory hormones. They are going to cause increase in glucose in the bloodstream, causing episodic hyperglycemia. Okay. Then in the findings, because it's coming from the neural cells, where the neural crest cells, it's going to be neural crest cells. It's going to be chromogranin positive, synaptophysin positive, and NSE positive. 3 things are going to be positive. You can screen for this. Screen for this by doing a 24 hours assay for assay for urinary metanephrines and catecholamines. So again, 24 hours urine, metanephrines, and catecholamines can be checked for the screening purposes. Okay, for the treatment, we have perioperative administration for very high yield, that irreversible alpha antagonists, for example, phenoxybenzamine, high ES yield, phenoxybenzamine, followed by the beta blocker prior to tumor resection. So you want to have tumor removed, right? But you don't just remove the tumor, because that tumor has a lot of catecholamines. When you're removing it, there's a highly likely chance that the preformed catecholamines will go into the blood, will work on your alpha receptor and cause hypertensive crisis, which can lead to death even, right? So you want to block that alpha receptors. To block the alpha receptor, you want to give alpha antagonist, and the irreversible alpha antagonist is going to be your phenoxybenzamine. So first you want to block this out, then you want to resect it so that whatever catecholamine goes out, they are not working on the alpha receptor. Followed by the beta blockade, prior to tumor resection. So alpha blockade must be achieved before giving beta blockers to avoid hypertensive crisis. A before B. A is alpha and B is beta. So A before B, alpha blockade first, beta blockade later. Phenoxybenzamine for pheochromocytoma, and that is also important, okay? With that, we are good to go for pheochromocytoma. Let's just quickly revise it. Pheochromocytoma, it is the most common tumor of adrenal medulla. It causes bone mets high yield. Okay, it is derived from chromophin cells from the neural crest. Because it's a neural crest, so it's going to be chromogranin positive, synaptophysin NSE positive. It is associated with a lot of things. For example, high yields is RET mutation, VHL. Actually, all of these 3 are high yield. Okay, it could be associated with all of them, or it could just arise sporadically. Okay. Rule of 10, 10% malignant, 10 bilateral, 10 in the paraganglion, bladder, or organ of Zucker candle. 10% calcified, 10% in children. Symptoms are again episodic headache, increase in blood pressure, increase in pain, which is headache, increase in sweating, tachycardia, pallor, polycythemia, because it increases EPO release. Symptoms occur in spell, which is relapses, and remits, which is again same thing saying as episodic. Okay. Findings again: increase in catecholamines, metanephrines, HVA, VMA, all are going to be increased in urine and in plasma. is going to cause hyperglycemia because it has increase in catecholamines. Uh, okay, then you want to resect this tumor, but you have to block alpha A first, then beta blocker. Alpha first because you want to block those alpha receptors before you can block the beta receptors, and phenoxybenzamine for irreversible alpha blockade, and that is all for pheochromocytoma. Okay, let me know in the comments. Do you guys want to finish these two leftover pages? We can start pharma tomorrow. So, or you would just do them tomorrow. Let me know. Well, I have time, uh, but let me know. Okay. Okay. Great. That's what I thought too. Thank you for saving me as well. Okay. So, good luck, guys. Thank you all for joining, and see you guys tomorrow. Thank you.